Dr. Chaitra will be talking on outcomes of socket reconstruction. Please start.
Good afternoon, everybody. I present to you the outcomes of socket reconstruction with concurrent use of spherical acrylic implants with mucous membrane grafting. A contracted socket, as we all know, is the shrinkage and shortening of all a part of orbital tissues, resulting in decrease in depth of the fornices and the orbital volume, and an inability to sustain a prosthesis. So the net volume loss post-enucleation and evisceration will result in the inferior and forward displacement of the intraorbital fat, and a larger prosthesis that is required to fit in will often depress superiorly and pushes against the lower eyelid inferiorly. So all this may lead to the development of post-enucleation socket syndrome, characterized by deepening of the upper eyelid sulcus and variable amounts of upper eyelid dysfunction, ranging from lag of thalmus to severe ptosis, and also stretching of the lower eyelid with inadequate eyelid closure. So the progressive stretching of the inferior fornix of the lower eyelid with the posterior tilt of the fornices or the gravitational effect of the heavier prosthesis will often lead to an ectropion development, which further reduces the fornix available to support the prosthesis, setting up a vicious cycle. So the lower eyelid and sulcus stretch inferiorly will lead to the prosthesis getting to sink. Therefore, larger prosthesis might be required, and this heavier prosthesis in turn places more weight or stretch in the lower eyelid. So an ideal socket reconstruction will require both volume correction and surface augmentation. The deficit volume corrected by an orbital implant restores most of the volume, leaving enough space for the prosthesis to be fit in, and adding tissues in the form of mucous membrane will serve as a replacement for the deficient conjunctiva. So the study was to evaluate the concurrent use of spherical orbital implant with mucous membrane grafting, which was a retrospective observational case series conducted at Kempegowda Institute of Medical Sciences, Bengaluru, over a span of 2 years, which included 30 patients who presented with contracted anophthalmic sockets and post-enucleation socket syndromes. So a socket reconstruction was done in all of them by the usage of a non-spherical PMMA implant, and mucous membrane grafting was done in all of them to both the upper and the lower eyelids, along with fornix-forming sutures. So 27 of them, that is 90% of the patients, had good sockets with adequate fornices for a well-fitting ocular prosthesis, while 2 of them, that is 6.6% of them, required revision of the fornices, while 1 of them required further surface correction. So this was one of the patients with right contracted anophthalmic socket presenting to us, who underwent the concurrent surface volume correction with non-spherical acrylic implant along with mucous membrane grafting, who had a good socket with an adequately fitting prosthesis at 10-week marks. This is another patient with good socket with an adequately fitting prosthesis, and the third patient with good results as well. So we can say that an ideal socket reconstruction will require both surface and volume augmentation for a well-fitting prosthesis. Non-porous spherical acrylic implants are widely used to ensure a good volume correction in contracted sockets. There's no additional advantage and outcomes with using orbital implants made from other materials like silicone or hydroxyapatite or metpore. Among the conventional autografts, the use of mucous membrane grafts is the only one useful in socket reconstruction because of its inherent properties. Thank you.
Would you please explain the procedure just in brief, the surgical procedure, just in brief? How did you approach the contracted socket for volume and for the surface reconstructions? You are using for that conjunctival fat for MMG. In between, how did you go for it?
So
you
the
didn't include a video, no?
Conjunctiva and the scar tissue were incised, ma'am, by horizontal incision, and the spherical, non-spherical, the spherical implant was placed in the scleral bag. Also, the sclera with suturing of the sclera and the conjunctiva. Then the buccal mucosal graft was harvested, and then.
So did you compare it to silicone and PMMA?
No, ma'am. This was all.
But
all
you
the patients
concluded
here,
saying
yeah,
that
there's no
it is.
additional advantage with using the.
But whatever you did, all of them were acrylic.
Yes, ma'am.